Thank you very much for giving me the opportunity of sharing my experience and my projects in this interesting conference, and special thanks to Jackie White and Caroline Triac for the support and the good work they are doing. I am going to talk about one project that I made with Adaptive. Adaptive is a company founded by myself and a French colleague, that's Pauline Fontaine. She studied science politics at Lille, and she has to master on health. And I met her as she was working at the French embassy in Spain as a trade advisor for French companies selling or trying to sell their products in Spain. The Optim project is about multiple sclerosis, as you can see here. As you know, multiple sclerosis is a very serious illness that creates big problems to the persons, social, clinical, and environment problems. So it's an interesting illness to try to solve in a broad sense of population health management. The project made at the Center of Public Multiple Sclerosis of Catalonia in the Hospital of Vall-d'Hebron, one of the biggest and maybe one of the best hospitals of Spain, and is a reference center for the Spanish Ministry of Health. So that means for all Spain. First, I want to make a comment about the group of collaborators we have had who wanted to have a broad vision of the approach to the illness. So you can see here that we had engineers, we had doctors, we had nurses working in the primary care, working in the administration, a health economist, and of course a computer science person that with a lot of knowledge on interpreting. Going to my personal background, just as nothing comes from nothing, just to better understand my interest in this illness and this approach, I have to comment with you that working in a public HMO, or maybe now we'll say ACO, we have developed a computerized longitudinal patient register with a unique identification using a patient card, with the objective of monitoring the healthcare services consumption. Also, we have I have promoted the first program on chronic disease management on cardiac heart failure when I was the director of primary care of Barcelona. And finally, when I was the CIO in Hospital São Pau, under the umbrella of the Spanish Ministry of Industry, we created with the Polytechnic University of Catalonia a living lab just to work together, doctors or physicians and engineers and nurses. The project was about integrated healthcare clinical pathway. As you can see, you used the topics that are the key in these projects: the clinical leadership, the quality of life for patient and outcomes, the clinical pathway, coordinated and integrated, and the use of ICT. As a care model, you may know this is from Right Care, is the accountable care that I think that this slide summarizes very well this concept. And another reference paper is this from Healthcare Management Review that is elaborated by Pauline, coming from the text that explains very clear where are the pillars and also where we have the barriers to develop a patient-centered innovation. What we have done, we have worked a lot. We have worked during 1 year and a half, almost full time. So there's a lot of work behind this. And as you can see here, we, of course, began with a patient's questionnaire to understand the experience of the patients, of the illness, and to understand what was the situation. And of course, in this case, the caregiver's questionnaire was important because it gives us the vision of the person who is helping another person that has a big need on this. Also, we had meetings with group meetings with the clinicians of the center and other healthcare professionals. And the main topic was clinical pathway, of course, but the subtopics, as you can see here in this slide, were 7, where we had the integral clinical pathway, but of course with the outcome of the IT platform. The role of nurses here is very important, so we worked a lot of nurses with this, the patient empowerment, engagement, and all these concepts around the patient, the health economics. Telerehabilitation, now we are talking about telehealth or telemedicine after COVID, but in some cases we are doing well, and some cases can be better, but in this case it's absolutely mandatory, it's necessary to do it. Research and these special characteristics of this illness needs to go hand by hand with the patient, with the problems, cognitive, physicals, and language disorders. Also, we have made some in-depth interviews, one with clinicians and healthcare workers, with 22 interviews, and special interviews trying to understand the situation in another places like UK, like Madrid, in other parts of Spain, just to understand and learn from other practices and to explore the feasibility to replicate the model. And finally, we had made a lot of field work with the permission of the patients, attending the visits, attending the counters, going to a swimming pool where the patient made his physical exercises, and of course rehabilitation at home, nursing homes, and trying to see the broad aspects of attending this illness. As typical, we have used the paper guidelines here, of course, the reference guide of NICE and the Spanish Guía de Práctica Clínica sobre Esclerosis Múltiple, that is very useful. And try to translate this to the field. This is an illustration of the algorithms around the decisions process in this illness. Going to outcomes and conclusions, one important is the healthcare model that even in all the illness, you have the first visit, the second visit, and the treatment plan here is needed to put together the treatment plan and the rehabilitation phase, depending on of course, the disability of the patient. And in this complex visit needs to put together more people than doctors and nurses. And you have here some of the professionals that have to work on this. The other is the definition of the platform that I have told you before. Of course, these are the 4 main points, and in this schema illustration puts the center on the empower, engage the patient, number 1. The other is connect the professionals, that are so many professionals that is needed a scheme, a network of professionals working around this, the connection of course, of patients and professionals, and at the end, the telerehabilitation that I have spoken before. Well, here are the functionalities of the platform. I am going not to read this, just to make understand that we focus it from one side, from the neurologists and nurses on the hospital, the physicians and nurses in the primary care, and of course the patients. So the functionalities had to be this broad approach. After this, we defined an information model that have a lot of schemas. I guess this is a summary, but it's just to be the basis to be used for future developments of application around this illness. To finish, the announcements to the group of directors of the center, and a special thanks to the quality coordinator, Marga Navarro, that she was from the Foundation of Sclerosis Multiple, that is linked to the International Federation of Multiple Sclerosis, and helped us to find the right persons in the right situations to understand the illness. So in this case, this foundation, non-profit organization, helped us a lot to try to find the best people. So this combination of organization is needed. Some of these slides were presented at this interesting conference that has been held in Lisbon, and the project was partially supported by Novartis. The rest of support came from the Center of Vall d'Hebron and from the Foundation of Multiple Sclerosis that I have explained it to you. To finish, well, just this quote is a little bit pretentious, but it's okay for me. And just to give you our email addresses, if you want to contact us. I am now working as a healthcare consultant in Spain and South America. I'm here trying to promote the ownership of data of the patients for the research and investigation, like my data or something similar. And Pauline Fontaine is doing a good work, working in France, in the hospitals, in clinical processes. We both will be happy to answer your questions or attend your comments. Thank you very much.
Hi, hello everyone. My name is Megan Stowe, and I'm going to talk to you about technology-enabled access to care. I'm presenting to you today from the west coast of Canada and British Columbia, and also the unceded traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. I work for Vancouver Coastal Health, which is a large health authority in British Columbia. We serve about 1.2 million people, or a quarter of British Columbia's population. We have urban, rural, and remote communities with a full spectrum of socioeconomic and culturally diverse backgrounds. In our health authority, we have over 17,000 dedicated staff and physicians, and spend about $3.8 billion on our community, hospital, and long-term care services annually. We also have a large affiliation with UBC, or University of British Columbia, and have about 103 million research funding dollars in the last year. We also have one of the top 5 foundations in Canada in terms of dollars raised with the mandate of investing in health system innovation. And so I have 2 topics I'm going to share with you today. The first is the transformation that we're undergoing with interpreting and translation services. So we know that 2 out of 10 of every patient or client has low English proficiency in our area. And to be honest, that's probably grossly underestimated. The impact of this is huge. About 86% of staff can't understand preferences, values, and needs for patients. We know that staff can't get a full assessment or history if they can't communicate well. And staff are unable to create a caring and therapeutic relationship with clients. This results in longer time and waits in the emergency department, as well as much longer hospital stays. And of course, with this, the risk is increased for functional decline, the risk for hospital-acquired infection, as well as a greater risk for falls. And so within British Columbia, we have access to translation services, and we put in about 35,000 requests per year within our health authority. However, that's probably underestimated, or we have a lot of unmet need. But from the services that we have currently, about 8% of those are unfilled. And we also pay for transport costs for our interpreters, and then also for any short-term or cancellation. And about a quarter of our budget for interpreting is wasted, so about $250,000 per year. And so there's this amazing solution that one of our nurses in one of our hospitals had heard about. And what basically it does is it connects within 20 seconds with either a video or verbal interpretation over an iPad. And there's 24-hour access to medically trained professional interpreters with over 240 languages. And the device is on wheels, and you can move it to the patient's bedside. So a lot of really incredible developments that are very different from what we have access to currently. And so this nurse with this idea was able to access innovation funds for a pilot and had really great early successes locally. But what we saw was the cost of accessing this was just too huge to even consider spreading it across our health authority. So we spent 18 months studying the technology, the best possible workflow, practice around use of the technology and have been successful in gaining funding for full organizational rollout. So what we've done is we've said, okay, this interpreting service is really fantastic, but let's put it as a part of an overall pathway for care. And so what we've said to clinicians is it's fine to use Google Translate for simple conversations. So daily activities or non-medical conversations like, can you sit up? Are you thirsty? Would you like to go for a walk? That type of thing. Then for the vast majority of our conversations that are medically based, we use the virtual interpreter, and it is broad use, and estimate probably 87% of the time that this will be what is used, but also realizing that sometimes in-person interpretation is needed. So for serious or critical conditions, highly emotional content, hands-on instruction, or individuals with dementia. And so with that, we have amazing results about the impact that this technology has made. We've had about a 47% reduction in length of stay for patients with low English proficiency. The readmission for these clients as well has decreased dramatically, about 70% after 7 days. Discharged from hospital, they're much less likely to be readmitted. We've seen no change in our 28-day readmission. We also know the decision to treat in the emergency department has reduced dramatically as well. And so moving on, the other example about accessing care is our virtual health work. And so virtual health has always been something that we've utilized in the province of British Columbia, but with the pandemic and the onset of COVID-19, we've had incredible uptake. And so our focus right now is really on video visits, so connecting a client and a clinician at a distance, the use of e-faxing for prescriptions, enabling texting with patients and between clinicians. And then we're also looking towards the future. We'll be providing a hospital at home as well as clinical texting. And so just some examples of the work that we've led for our organization. So prior to the pandemic, about 3% of our activity was virtual. But with the onset of COVID-19, we transitioned to host between 4,500 and 7,000 virtual visits per week. This has been going on since March. And so those virtual visits can include physician consults, visits with physiotherapists, occupational therapists, and nurses, large group rehabilitation. We've set up a virtual choir with one of our long-term care facilities and intensive care rounds. And so with COVID-19, oftentimes family can't come into the hospital, but we include them on the intensive care rounds with the clinicians that are visiting with the ill individuals. We also have avoided about 6,000 waiting room waits since September. And so with this technology, we're able to have clients that are in the emergency department get text to come back to receive the results. We run a full flu campaign using this technology as well. And also in our ambulatory areas, we don't encourage people to sit and wait to be seen. We actually text them when they're ready to be seen. And also, lastly, with the faxing, we did not have access to fax prescriptions prior to the pandemic, but with the onset of COVID-19, we've been able to have about 17,000 prescriptions since April sent. As well, we're able to fax the rehabilitation equipment requisitions too, which has been very impactful for our organization. But with the shift of virtual from about 3% to 95 to 100% in some areas, we became really concerned about making sure that the patient was seeing the right person at the right time in the right place. And so a lot of effort and focus has been going into making sure that a virtual visit is appropriate. And so I'm just going to share where we're at with this work. So basing our developments on the BC Quality Dimensions, BC Quality Matrix Dimensions of Quality, we've introduced 7 trigger questions for clinicians or clinical areas to review prior to setting up virtual visits. And basically, the trigger questions elicit a yes or no answer and then provide an opportunity to make the best possible decision about next steps. So an example of this would be, does the client or patient want to have a virtual visit? Will having the virtual visit minimize harm? Does the virtual visit an appropriate choice for this client or population? And will it support or maintain equity of care? So the idea is if anyone answers no to any of those questions, it actually is an opportunity to take a step back and really think if this is the most appropriate step. And so what is the difference that the virtual visits are making? Well, first of all, we know that having a connection virtually saves the patient or client loads of money. And so we're estimating about $18.5 million saved annually by patients. And so that includes savings from parking, transport, time off work, caregiving costs. It's tremendously impactful. We also know that the utilization of our emergency department following virtual visits has decreased, and we're really trying to understand that better and to look into that and understand what the connection is there. And then lastly, we've had a massive increase to attendance for our education sessions, between 30 to 50%. And this is down to the fact that we can have an increased capacity of individuals accessing education, but there's also much more flexibility. Thank you.
Hello, this is Al Mully. It's a privilege for me to be here in this global summit for population health with the King's Fund and NHS England and NHS Improvement. I have a sense, even though we're doing this virtually, of what Joseph and Megan spoke about in the sessions that they are doing before this one. And I'm going to take a somewhat different approach. I'm not going to talk about a specific project that we've been doing here at Dartmouth or elsewhere in the US, or the work that I've been doing lately in the UK. What I'm going to do is to set a direction for what I think is the most important future for population health management, and that is building a learning front end of healthcare systems in community-oriented primary care. A little bit of a comment about where my biases come from, because some of them are going to be pretty evident to you. I made a decision very early on in my life when I was a teenager that I was going to study medicine, but I was also going to study medicine where I could learn economics. I felt very strongly about access to health because of the conditions in which I was born into. And it was very important to me to understand how policy could make a difference for people living with inequalities and the social determinants of health. I did that at Harvard. I was at Harvard for 40 years before moving to Dartmouth a decade ago, moving back to Dartmouth. I was an undergraduate here. And what I learned from economists was the importance of making really good decisions. And that it's difficult to do that alone, to make and implement good decisions when they're important. And it also requires that one pay attention to the choices you have, the probability of different outcomes with the different choices you have. And not only do your best to estimate the probabilities based on evidence, but understand what the outcomes will mean in the lives of people who will live with them. And from the beginning of my clinical career, therefore, I was committed to understanding how we make choices matter for people's health and well-being. I'm just going to give you a little bit of an introduction to this history. This next slide shows a picture of Massachusetts General Hospital. It's where I began my clinical training as a medical student. I went off to the Kennedy School of Government across the river for a year to study economics, and then came back and did the rest of my training and served there for 35 years, nearly 30 of which I was chief of general medicine, responsible for both acute care and primary care. It was when I was attending physician in the intensive treatment unit at Massachusetts General Hospital, back in 1980, that I had an insight about the importance of understanding not just the probability of survival for a patient undergoing intensive treatment, but also really understanding how that patient and their family felt about the where, when, and how they were going to die. And to some extent, that was the beginning of preference-sensitive care. The decision was much more sensitive to how they felt than to probabilities that would come from evidence. It was also the point in time where I made the distinction between warranted and unwarranted variation. So the notion of measuring decision quality rather than just outcomes became very important. You can't judge the quality of an outcome made in the face of uncertainty, the quality of a decision made in the face of uncertainty by its outcome. Think about that. We should pay a lot more attention to that in healthcare. The other point is that this is equally, if not more relevant in the community setting. In 1967, Massachusetts General Hospital made an extraordinary commitment in investing in a community-oriented primary care center in a poor community just north of the hospital in Boston. 4 years later, they did the same thing in the community that I was born into, at the time, the poorest community in the state of Massachusetts. And that had lots of implications for understanding how you build a learning front end within the community where people have not only the right, but the duty to be engaged in the design and implementation of their healthcare. This is the notion of community-oriented primary care that came out of South Africa through the work of Sidney and Emily Kark in the 40s, had profound effects in South America, in Europe, in Asia. I had the privilege of going to China in 1978 to see it in action in what was called the first rural cooperative scheme in China, dominated by the work of barefoot doctors. There's also a series of other things that led to a foundation for the MGH to lead in population health management among tertiary hospitals, both before and after the Affordable Care Act was passed. For instance, many of the programs that I participated in and led to, for instance, people like Tim Ferriss leading population health management. Tim is now chief executive of the physician organization at MGH and also a board member of NHS-E&I. So about the time I recognized the importance of decision quality in the intensive treatment unit and in primary care, Jack Wenberg published his first clinical paper about practice variation. The first author was Clem McPherson, who was at the London School and at Oxford at the time. And it really got my attention. I introduced myself to Jack. Dartmouth was just 100 miles north of Boston. And we began to work together at that point. And as you probably all know by now, that led to understanding of geographic variation in the intensity of care. In the US by 1996, Jack had published the Dartmouth Atlas of Healthcare, and we found that we spent 3 times as much on Medicare beneficiaries in Miami as we did in Minneapolis. And then Elliot Fisher did a series of studies that demonstrated that if we spent 3 times as much in one population as opposed to another, we got no better outcomes in mortality or physical or mental or social function, longer waits for patients to see the doctors rather than shorter, more difficulty for doctors to make referrals to consultants and urgent care, poorer clinician-patient relationships leading to dissatisfaction and burnout, underuse, and the question is, what are the causes of this apparent waste? If you spend 3 times as much, not as good outcomes. And the causes are underuse of effective care that people need, and overuse and underuse of what we could call preference-sensitive care, when the decision depends not only on what the evidence tells us about probability of outcomes, but upon the context in which that individual and perhaps their family live, and the preferences they have as a result. And if we allow easily avoidable ignorance at the front lines when these decisions are being made in the community and in the acute setting, if we allow there to be easily avoidable ignorance there about what's realistically possible and what would be most valued, that easily avoidable ignorance permeates the system. The decisions about investing in capacity are made in the face of easily avoidable ignorance about what people need and want in aggregate. And if we invest based on current use without recognizing the assumptions that need to be challenged about what makes a difference in health and well-being, then we just perpetuate the oversupply and overuse of supply-sensitive care. Now, when I moved to Dartmouth from Harvard, I was recruited by then President Jim Yong Kim, who went on 3 years later to be president of the World Bank. And his recruitment of me was to try and bring greater international awareness of and impact from the research that I had been doing with Jack and others at Dartmouth, and as well as colleagues at Massachusetts General Hospital. There were some resources attached to this recruitment, and one of the things we decided to do was to see how relevant this understanding of healthcare was in different contexts, to test hypotheses about context specificity of what works in different systems. Over a period of 8 years, Dartmouth either led or co-led a series of 8 global summits, if you will, global seminars. And we addressed topics like the greatest untapped resource in healthcare, informing and involving patients in decisions, innovating for value in healthcare delivery, realizing the right to health. We did that with the World Bank, as well as achieving sustainable high-value healthcare by maximizing cross-border learning, new paradigms for mental and behavioral healthcare. One of the things we found is that focusing on a population with difficulties related to mental and behavioral healthcare, or focusing on a population nearing the end of life, or focusing on a population of people with dementia or their carers, is very, very helpful in understanding how to think about population health if you're going to address the needs of the vulnerable, the marginalized, if you're going to address inequalities and the social determinants. And we came to become increasingly confident that there was a great deal about healthcare across the globe that was universal rather than context specific. That was very helpful because another condition for my moving from Harvard to Dartmouth in 2010, end of 2010, was to start from scratch in building a new model of primary care. And I saw this as a model designed for population health management. What we did was we said, if we were going to build this model for the 4,000 Dartmouth employees that it will serve, we might have 4 GPs and 2 nurses and 2 receptionists. But that might lead to maybe 10 minutes per consultation, as is often the case in the UK, between a GP and a patient. So instead, what we did is we halved the clinical time. We halved the number of doctors from 4 to 2, the number of nurses from 2 to 1. And we didn't have any receptionists. We hired people for their relational skills, their cleverness, whether they had any prior experience in healthcare. And we trained them. We trained them to learn from patients what they needed and wanted. Basically, it was elements of shared decision-making, motivational interviewing. We also used data. Those health coaches would meet every morning with the nurse and the 2 GPs, and they would huddle. And they would begin with the data, but then they would have real-time information about what was going on in the lives of the patients who weren't able to manage their condition as well as hoped. The coach over on the right is a wonderful story. This model came from Atlanticare. It was developed in collaboration with Dartmouth by Iora, a colleague of mine at Massachusetts General Hospital, Rushika Fernandopoul. Maybe more to talk about that in the question and answer session. Now, expanding this notion of learning from patients to meet the strategic intent of providing people with the care they need and want, no less but no more, the impact when you expand that thinking to the social determinants is even greater. Over on the left, you see a very clever graphic demonstrating the relatively modest contribution that we make to health and well-being over the life course in healthcare narrowly defined, and the much greater impact that social determinants have, and how many of those social determinants are related to inequalities, marginalization, and vulnerability. And I could give you many, many examples of the kind of overuse that can be avoided when you think about this community-oriented primary care model with people who really engage to understand needs and wants. For instance, in Birmingham, when we were working with vanguards across the country, we heard a story about a woman who had her hip replaced after being referred by the GP to a consultant. And during the re-enablement period, she was so surprised at how difficult it was and so surprised about what she couldn't do as a result. She said to the GP, "I wish I had known. All I really needed was for my banister to be repaired so I wouldn't be so lonely not being able to walk down to see the postman in the morning." We need to stop replacing hips rather than repairing banisters when that's what the patient needs and wants. Now, the implications of this, I think, are really important for the kinds of communities where we need to address inequalities and social determinants the most. Those are the communities where most of us in healthcare have the most to learn. And this is the same picture, but I've switched the books up at the top if you have a chance to see these slides later. And the notion is that if we intentionally train a workforce where we can have 3 to 5 of these trained new workers working with every GP or working with social workers or working within the public health system, we can triple the amount of time to learn from patients, and also to influence them with shared decision-making, with motivational interviewing. Motivational interviewing has been applied not only to healthcare, but to social work and to mental health with adaptation around cognitive behavioral therapy. We know all of those things work. It's just that most of us work in systems that don't have the time to do it. We need to expand that time. Now, the final slide here, I apologize for it. It couldn't be more complex looking, but I want to make a couple of simple points with it. No one can make a good decision alone. You can't judge the quality of a decision made in the face of uncertainty by its outcome. We need to have systems that recognize that way of thinking about decisions made in healthcare and willing to measure the quality of the decisions. That's a longer discussion as well. But our work, both in the United States and in the UK and elsewhere, has convinced us that people working at the front lines of care are prepared. They want to be the team that is the learning front end of a healthcare system, so we give people the care they need and want, no less but no more. This graph, just very quickly, this is all very theoretical, but in the work we've been doing, every time we talk for 10 minutes about the direction of change, we give people a measure or tool specific to their role in the system to let them take the first credible step. And these measures are designed for learning, simple measures like collaborate and integrate. Does the patient feel known? Does this patient feel known enough by a team? Is the team visible to them? Do they trust the individual GP or the team that they're working with? Those are all things that individual GPs and the teams they work with can learn very, very quickly. And these measures and tools go from the front lines of delivery all the way up through the system to senior leadership roles, where you might use a systems dynamic model to understand how long you have to wait to get a return on investment in population health management, rather than set terribly unrealistic expectations for those at the front lines. So the notion here is that we need to invest in frontline learning from patients about their needs and wants, and the people who manage systems and manage population health have to understand the importance of that. If we do, there's the opportunity to redesign the system, invest in different capacities like these new workers, and let community-oriented population health become the engines for inclusive economic growth in the communities that are troubled so much as they are by inequalities and social determinants. Thank you for listening.
Good morning, or afternoon actually in the UK, but we welcome to our next session on international experience of population health and population health management. I say in the UK because we have some very early risers in Canada and the United States. We're very fortunate to have them here. Before I kick off with the first question from you all, please keep them coming in on Slido. Can I just ask Pauline to introduce herself, because I don't think you've seen her on the video content, but she's here alongside us today, and then we'll go into questions. Thank you.
Hello, everyone. My name is Pauline Fontaine, and I was the co-founder of Adaptive Healthcare Services along with Joseph Picasse, who was leading the presentation. And we worked with this company around population healthcare management, and we presented the project of multiple sclerosis, in which I was deeply involved with the consulting part.
Thank you, Pauline. That's great. So welcome to you too. So we will go, I can assure you, we're going to go straight into your questions in a second. But first of all, given this is an international session, I thought it'd be good for our speakers just to say a little bit about population health and population health management in their own countries, and to the extent that they wish to or have the knowledge, how that might be similar to where we are in England and the UK more broadly, or different. Just a few opening reflections about how important this movement, I would say, is for population health in their countries. So I don't know who wants to go first. I should probably ask somebody, but Al, I think you may want to say a little bit first. Thank you.
Well, population health in the United States is really about 20 years old in terms of the way we describe it now. It began in focusing on understanding what individual patients wanted, and very quickly moved at about the time the combined predictive model was developed in the UK towards using data to segment populations. The most effective approaches to population health management have been achieved both in major medical centers, including those run by acute hospitals or led by acute hospitals, but also in primary care settings. The impact on cost and outcomes is still very variable around the country. There is some evidence that those that are based in primary care settings with that kind of orientation are more successful.
Thank you, Alan. And I know there's a lot of learning from the institution that you work for, and thank you for the presentation earlier on. I don't know whether, Pauline, you might want to say you might have experience in France to kick us off with.
Sure. So in France, of course, we came after United States, because United States is always kind of the first to launch those kind of approaches. I would say in France, it's about 10 years old, the approach of population healthcare management. And as you may know, so we have the health ministry that gives all the strategies to implement. And then we have in France all the regions who have their own health regional agency. And those health regional agency have financing to launch projects. And we can see on the last years that a lot of projects have been launched on population healthcare management. And we have a special kind of financing called Article 51 that enables to try new approaches on healthcare, and they give special financing, and when they're tested, if they're successful, they can go on different other territories. So we can see a lot of new approaches coming, especially on, of course, chronic diseases. So in France, what is most work would be diabetes and heart failure at the moment, but new pathologies are also tried at the moment in some of the regions. Going to hand over maybe to Joseph to talk about Spain.
Yeah. Please do, Joseph. Please, yeah, please tell us a little bit about Spain. But I think first off, it's quite interesting how both maybe my understanding United States and France differs a little bit from the UK, in that you have specific innovative funding routes, and we've got a session on innovation. The next big session is on innovation, so maybe we can pick some of these international differences up there too. So sorry, Joseph, to interrupt.
No problem. No, in Spain, as you may know, we have a thing that is very interesting, that is the primary care is fully informatized, is computerized, as in all over Spain. So that eases to get data from the patients. The problem is that we don't have this situation in the social services that have a lot of problems to have data. For this reason, the projects on population health management are just beginning the last maybe 4 or 5 years, and even today, I would say. No, and there are 2 regions that are trying to do a very good work. One is the region of Castilla and León in the center of Spain. That is a very powerful minister of health of the region that has improved a lot of working together healthcare system and social system. And the other is my region, Catalonia, that is now beginning an interesting project putting together social services, healthcare services, working with companies that know very well the marketing in selling marketing in the profiles of the persons who will try to translate to sell the marketing of selling bananas to selling health, maybe. Okay.
That's interesting. Bananas are good for health, aren't they? I think they're full of potassium.
Yes.
But interesting. Yes, we have a similar thing around in England around PPE. Various people selling PPE into our system. But anyway, that's another matter entirely. Megan, I don't know whether you'd like to say a little bit about Canada or Vancouver or British Columbia.
Absolutely. So Canada, with our large geography, has an entirely public system, publicly funded for our healthcare, and each province has their own specific system that's set up. Our population and public health really relies on data and data sharing between our different organizations. And the greatest challenge that we have in British Columbia is the rural and remote population. We have a massive geography, about 7 times the size of England, yet England has 13 times our population. So you can imagine with huge mountain ranges and individuals that are isolated by water, we really struggle to make sure that there's equal access. We're also very focused on our Indigenous population and ensuring that they have adequate and appropriate health care. And it's hard. Some of our areas don't even have, running water that is safe to drink. So we've got lots of challenges that way, and a lot of creativity and innovation to support as well.
Thanks very much. And that I think all nations, however densely populated, have elements of these problems. We have very low density populations in the UK even. So I think your presentation is really helpful around that, and also cultural differences, etc. And that probably, so thank you all. That probably brings me to the first question, really. And we got the first question, the most popular question so far. And I think Al, you might want to pick an element of this up, is we know that Black, Asian and other minority ethnic communities have been most adversely affected by COVID-19 in the UK. Where is the approach from Black countries in this international approach? So I think that's a very good challenge to us, frankly, as conference organisers, about wanting more diversity in our conferences. But I do think, Al, particularly from your experience, you've worked with many countries on population health management. So you wanted just to say a little bit about your experience amongst those sort of countries and populations. Oh, sorry, Al, I think you're on mute.
That's better. Let me just reference the slide that I put up very briefly to talk about the intentional effort we made over the last decade at Dartmouth to learn from countries around the world, either hosting or co-hosting with others, foundations, other universities, these meetings in Salzburg, where we addressed questions of population health, often with a focus on vulnerable populations. Having seen that question, I counted in my head, and I can confidently say that roughly 25% to 35% of the countries represented over the period of that time at those meetings were from Africa. And the reason was we felt we had a great deal to learn from people who were used to implementing community-oriented primary care, which really began in the townships of South Africa in the 40s, and making good use of community health workers and making good use of assets in communities. So we saw it as an opportunity for us to learn how we could get away from the hierarchical thinking that comes with a focus on science and technology as the key to health and well-being, as opposed to community assets and building upon them.
Thank you, Al. And I think the question and your response is a really good reminder, I think, about population health, that population health starts with populations and who they are and what their needs, assets and aspirations and challenges are. And then, as you say, our our system-wide approaches need to build on that as opposed to sort of bypass it. So thank you very much, and thanks for the question. Another really good question, and I think maybe Pauline might want to pick this one up, is about from David Hammond, about the fascinating question of power dynamics underlying discussions of population health management and expert doing to versus care that people need, and that we in the NHS and say all the other systems have struggled with, I guess, person-centered shared care. But I think, Pauline, you had something to say about that from your experience.
Sure. So about our project in multiple sclerosis, we did take a patient-centered approach. That was very, very important for us, and we put it first at the first moment. What we did is really a deep analysis of the needs of the patients. We actually went to their home with a questionnaire and visited several of them. There are different kind of multiple sclerosis, so we really segmented the patients, and we visited all the profiles that we could find and really talked about their needs. We even, for the anecdote, went to the swimming pool for them because swimming and water is very important in the care of multiple sclerosis. So we really gone deep on what they were needing, and then we translated that into technology. Is how can technology help their needs? So it was really the full project was centered more on the patient than the need of the professionals. For example, we did study also the professional. We went to the consultations with all the professionals, but our first need was to understand what the patient, what was important for the patients to have a better care. And we did translate that into the technology. So for me, the patient-centered care is very, very important and should be the approach that people take on their projects. I don't know if Josep wants to add something about that, but no. But this is really a concept that we can see is rising in a lot of countries. Actually, in France, it's also the same. In the new documents of the Ministry of Health, it is something that is really put first. And it's a switch because it wasn't the case a few years ago, and we see that now professionals and institutions understand the need of putting the patient first. I don't know if Al, you can get on this one on the US.
Yes, just taking a step back and making a general observation. There are three prevailing assumptions that most people, policymakers, clinicians, patients, and citizens subscribe to about healthcare. One is that healthcare is highly trained people who know science and technology doing things to people who can't do those things for themselves. When in fact, much of healthcare is the bidirectional exchange of information about what's possible and what would be valued. And without that bidirectional exchange, we don't make very good decisions about what people need and want. The second assumption is that evidence tells us what the right thing to do is. When in fact patient preferences matter, and their willingness to make or not make trade-offs are critically important if we're going to give people the care they need and want, no less but no more, which should be the strategic intent of population management. You take those two assumptions and they add up to the belief that the more we spend on healthcare, the better the health and well-being. And increasingly, we recognize that that's not the case. It's the life circumstances that contribute far more. The life circumstances and the behavior, including the way choices are constrained by life circumstances, that contributes far more to health and well-being. So we need to learn from patients primarily.
Thank you, both of you. And we might come back to this. I guess, the previous session we had was very strong on data and how important data is in terms of the glue and analysis of it, connecting the healthcare experiences and the wider social determinants of health, how important that is for the future, how important that you feel that is in your system. Megan, do you want to come in?
I just wanted to share that we've just completed a recent poll of all the patients with the virtual visits that we've done. And what has been so fascinating to me is that the patients and clients and families that we've asked about their experience feel that they will adhere to their treatment plan much more than they would have if they'd had an in-person visit, just because of the challenges with COVID. But adversely, the clinicians feel that they aren't providing adequate care this way. So it's put us in a really fascinating conundrum with diverse opinions. And I honestly don't think that, you can turn away from that type of feedback from patients and families. I think it's essential. I also think it begins at the start of any project or initiative. It has to be woven in initially and really made sure that it's integrated into all of the planning.
Thank you so much. So maybe you want to continue that line a little bit, because one of the questions I was going to come to you with was around how important digital inclusion, which is a phrase, I don't know whether it's a phrase in Canada, but it's certainly in the UK, which is about who's in and who's out of digital, and what does that imply? What does that mean, given we've all been forced into digital relationships across our lives to some extent, and what the benefits and I guess and the risks of that are, and as you say, what's really fascinating, what you've just said, is about who perceives what as a risk and a benefit. And the point goes back to, I guess, Al's point about are we, particularly as medical professionals, in a way not taking as much notice of people's preferences as we should be. So I don't know whether you want to explore that in relation to the work that you shared earlier on.
Absolutely. So I haven't actually heard the phrase digital inclusion, but we do talk about it all the time. And it's really about driving healthcare decisions and initiatives, making sure that we have access to appropriate tools and information. And I think it's a very diverse topic because there's so many parts and pieces to that, including kind of our privacy and legislation. It can be a real barrier to some of these types of tools. But I think it really comes down to core values about making sure, that the choice around data and digital solutions is really driven by what's best for care, and that the patient's in the center of that. And also the integration of all these different pieces of information and resources is a real challenge in our system. When you think about having, one record of care, one source of information, it can create quite a storm of data and information. But the other piece is that oftentimes, if you think simplistically about access to virtual solutions, it can really just be for a subset of the population that owns, equipment and devices. And so we've been really struggling to really think about how to be quite creative. And we've had some partnerships with some nonprofit organizations. And actually, we have a population within Vancouver called the Downtown East Side, and a lot of individuals that might not have access to technology, and have been able to give them phones during COVID so that we can stay in constant communication. It's been a really great resource for us. But I think you have to get quite creative and know your population really, really well to consider how, to best support.
Thanks very much. And for me, I guess it's both ends of technology, isn't it? One is that very simple in a way, give people access. If they're too poor to have a phone, give people access to one. And is that an appropriate role for a healthcare institution, which is a big question? I think the answer is yes, from my perspective, if it's all about health. Two, the analysis and integration of complex data streams, allowing you to plan either care for an individual or a group or a place. And I guess acting along that spectrum with a focus on patient preferences alongside. Easy thing to say, but that's really helpful. We've got a couple of more specific questions. I don't know whether Pauline or Josep wants to pick them up. One was about the relationship working with the pharmaceutical industry from your research, and how comfortable did that feel? What did that mean? And the other one was something about focus on whether you focus on lifestyle changes in your work on multiple sclerosis as well. And then we'll come back to some more broader questions. But thanks, Megan, for that. So I don't know whether Josep want to pick up one of those.
I am going to pick up the pharmaceutical industry. That is a not easy situation. In Spain has been historically participation of the pharmaceutical industry in the training of doctors in the hospitals and so on. So has been not budget in the National Health Service for this training, and this training has been paid by pharmaceutical industry. That has created sometimes very complicated situations and not good situations, of course. I will not say another thing. That has been more or less begin to be to change some years ago, 10, 15 years ago, with a movement of doctors that they wanted to work with the pharmaceutical industry as a payers for the training or for the projects. And now most of the projects, maybe I will say all the projects, are made through the research institutes of the hospitals. That means that ethical committees sees what happens and evaluates what happens. It's not solved, but is in the way of solving. In our case, there, as always, as Gauss curve, there are some doctors enthusiastic with this cooperation, and there are some doctors that hate this cooperation. Of course, that is it. I think that time from time is evolving in the good way, and as ethical approach is gaining in the general feeling of the people as a good way to go. I think that will be solved, but it's still sometimes is still a problem.
Just wanted to add something to that. Also, I think it came to that because there's a lack of financing in Spain. I can see the difference because I've worked in Spain and in France, and in France we do have financing for projects. In Spain, it is really lacking. So they had to do something, and there's no other choice. So sometimes we have collaboration with pharmaceutical industry. It is really restricted to some areas, and it really checked, as Joseph said, by ethical committees. But there's no choice, because if we don't do that, there's no innovation, because basically the financing through the government and the regions, the autonomous communities, are very low. So it's something that has to happen, because also the government doesn't put money on this field, at least not enough money to launch those kind of projects. I don't know if maybe David, you want me to go on with the diet?
Yeah,
diet and lifestyle?
Yes, in a second. I guess whether anyone else has any thoughts about
sure.
with I guess pharmaceutical industry or industry more generally, because there are both I guess issues with that, but also potential real benefits. It seems to me. So Megan.
I just want to share that we have quite a few excellent examples of those types of partnerships, but I would just say that we're always quite cautious about what the relationship looks like, the transparency and the communication around those pieces. But we've had amazing improvements and outcomes come from relationships with private, and we really try to encourage those types of synergisms, but always, the diligence at the very upfront, just about all of the, what the agreement looks like and whatnot. But it seems to be a really clever way to support initiatives if you're, quite diligent in the approach.
If I could just quickly,
please, Al.
David. So years ago, Jack Wenberg and I founded something called the Foundation for Informed Medical Decision Making, and it was designed to deal with this problem. And what we tried to do was designate what the great concern was about working with the device industry, the pharmaceutical industry, and other commercial interests in healthcare. And what we decided was that the key was not to put them not into a partnership where they could influence the clinical decisions that were being made for each patient. So we wouldn't work with device and pharmaceutical industry colleagues if that was a necessary part of the collaboration from their point of view. And we had a board that was meant to keep that firewall secure, so that we weren't in partnerships that was creating not supplier-induced demand at the clinical level, but supplier-induced demand at the device and pharmaceutical manufacturing level.
Thank you so much, and so thank you, because I think this connection with industry is really critical in population health management, isn't it? Both the pharmaceuticals, but also, I mean, we haven't come on to this, but maybe we can, if we get time, the data industry, the Googles of this world, the Amazons, etc. That integrating that data, potentially enormously powerful, but also all sorts of issues with it. But let's park that one for a minute. So Pauline, please do follow up on a diet and physical activity, lifestyle type advice.
So yes, the answer to the question is yes, we did take that into account in our analysis when we began the project. It was really an integrated analysis, and actually the center where we did the project is SEMCAT, and SEMCAT has the neurology part, but also has another floor with all the other specialties that a patient needs. So it was the perfect place to actually understand the patient needs. And inside those needs, we did work with lifestyle and diet. We had professionals dedicated to that. And what we also tried to do is connect this center with the primary care. As Josep said, in Spain, the primary care is very well informatized, and they're directly linked to the hospital of the area. So it's really helpful to developing projects because they already have connection between the hospitals and the primary care. But in the multiple sclerosis, what we saw is that the primary care was not aware at all of multiple sclerosis. Actually, we got even one doctor, primary care doctor, a nurse, that told us, the first time I had a patient, and I had one in my life, I didn't even know what multiple sclerosis was. So I had to look on Wikipedia to know what the disease was. So also one of the objectives of the platform was to enable professionals from the primary care to understand multiple sclerosis and to be fully integrated in the care, because we know that it's much less costly for a patient to go to the primary care to be treated for some part of the disease and only go to the hospital when required, for example, for a neurology consultation. So the platform was also developed so that the primary care was taken into it, so that they could also help the patient with the diet and the lifestyle parts. So it was definitely two things that we did take into account in the approach.
Thank you, Pauline. And now a pretty broad question for you all, actually. So whoever wants to come in, there's a question from Alex Bax, who's talked about the experience in England, at least, or the UK. So in England, for the just a bit of context, I think about 15,000 homeless people, as part of COVID response to COVID, have been placed into accommodation, and homelessness has been, as for everybody, is a pernicious and long-term challenge. Yet suddenly we could take 15,000 people off the streets and put them into hotels and various capacity, very COVID safe. So I guess one question from Alex is, to what extent should population health management approaches, or people concerned with population health in sort of the positions that you are in or your systems are in, actually engage with the political determinants of health, as he has phrased it? So really, I guess this is an advocacy question as much as a responsibility question. So a very big question. I wonder if A, any reflections on that, and B, particularly from your, is this a debate that is going on in your countries spurred by COVID, and how are particularly medical healthcare organisations or systems sort of reacting or responding? So a really big question. So sorry to throw that one at you, but I've gone on for quite at length, so you've had a bit of time to think. So, Al, looks like you're ready to start.
Oh no, well, I don't feel ready, but I'll. So I think it is really helpful when you think about what we need to really restructure in order to achieve strategic population health that is built upon gathering the critical intelligence that comes from knowing what an individual needs and wants, as opposed to making generalizations from data or generalizations from evidence, to focus on vulnerable populations. If you ask teams to think about where do you have the most to learn about improving health and well-being for homeless people, they very quickly realize that it's not at the King's Fund, forgive me, David, or at Skipton House or Richmond House or any places of power and authority, political authority within any of our health systems. It's from the homeless people themselves. What are they dealing with? What are the jobs they have to accomplish to get through a day and feel some bit of agency and personhood? And there have been programs in the U.S. and in countries around the world that have done that. That have canvassed homeless people on the coldest nights of the year to learn how many of them are dealing with serious mental illness problems, or how many of them are dealing with simply resource problems that somebody characterized as political determinants of health and well-being. So I will just respond that way. It's very easy to get people to take a logic model and ask them to find a first credible step in the direction of improving health and well-being for a vulnerable population, whether it's frailty, whether it's dementia, whether it's mental health problems, whether it's homelessness. And they very quickly realize where they have the most to learn, and it's from those people.
Thank you, Al. That's really helpful. I know Megan wants to come in, but I think that's potentially where the data, stitching the wider determinant strokes, the data together can help bring that realization in one way. Actually speaking to people at the end of the chain is the other way to do it. I mean, we probably need both, but thank you very much. Megan, did you want to say something?
I did. I just wanted to add in that we've been using this phrase, the COVID silver lining, amazing things that have happened in this international crisis that we never thought that we could accomplish or do. And so we've been able to support our homeless population in a very similar way. And what I wanted to share is I think that we have an opportunity coming up as leaders to really call out and put a stake in the ground in areas and spaces that we don't want to see ourselves recede. And what I'm worried about for our own organization within British Columbia is that we want to go back to the old normal, and whereas I think we have to be very deliberate in creating a new normal after all of these amazing, innovative things that have come out of this incredible crisis.
Thank you. Well said. And Josep or Pauline, any reflections or response? And how is that? Does that feel relevant with you? What Alan and Megan have said in terms of what's going on in Spain and France?
I completely agree with Megan on my side. I think Joseph does agree too. I think we have to learn our lesson, and it would be a wrong choice to just go on like if nothing happened. We did learn a lot during this crisis. It's been very hard on a lot of people, but we did achieve a lot of wonderful things in this time. And as Megan said, we never, if a year ago they had told us that we would do that, I think nobody would have believed it. And in the case of France, they also did solve temporarily the housing problem. You have to know that in France, the housing problem is really an issue, especially because people are a lot centered around Paris, and a lot of people are homeless. Or are living in very, very bad conditions, and it is affecting their health. So we have to change the mindset, and we have to put some new financing for helping also those people. In France, it's something that is definitely already taken into account. Like a group inside the ministry is working on this, like how we can learn from COVID and what we can put in place to change also the other determinants, like for example housing. Or economic policy. So it's something that is taken into account. Now we have to see in the future what they really do, like how you translate that to action. And I really hope that it will be translated into something powerful, because I think in the end it would also have a good positive impact on healthcare. If you give better housing condition and better economic conditions to people, their health is better. So in the end, it's also less costly for the system. So I think it's one angle that we could work on.
Thank you.
If I can, only 2 minutes.
One quick question to all of you before we have to end. Sorry, Josep.
Now, and just to link this to the future, you know that the problem with COVID is the long COVID, the post-COVID symptoms. No, so for advance to this and for advance on population health management, we need more data from the patients. And the only people that the only way of getting this data is through the volunteer of the patients of giving their data. This is a movement that is my data. I am participating in a movement in Spain that is Saluscop, that wants to convince the patients and the people and the citizens to give their health data for the research. So I think that this will help in the post-COVID era, but also with the population health management.
Thank you very much. One quick question to all of you. So single word answers if you can. What single thing can England and the UK learn from your system on population health, and what can we learn from you? Just a quick response. I know that's unfair on you.
I'll just add, I think the word impossible is just an opinion, and that by sharing and looking at examples for Canada to the UK or vice versa, I think is the best way to create relationships and learn and grow.
Thank you. Anybody else?
I would say models of care that are designed to learn from patients with new roles that can actually use the tools that we know work but haven't built the time in our systems for. I'm talking about my last comment in the recorded. We know motivational interviewing works. We know shared decision making works. We know cognitive behavioral therapy works. And it isn't being done at the level that it needs to be done in any country in the world, because we haven't built the workforce to do that. And were we to reach into the poorest communities in our country and the UK and in other countries to find really relationally skilled people and train them in further education or community colleges to do that, we would so much supplement the data that we have to manage population health that it could be, it could be reaching the goal of the Declaration of Alma-Ata, which was the fact that people have not only a right, but a responsibility to be involved in the design and delivery of their healthcare.
Thank you. That's a great way to sum up. And I guess, I think there's lots of, again, talking about silver lining of the pandemic is a strange phrase to have, but it feels like there's a real groundswell of recognition of that. And let's not go back, as Pauline said. So Pauline, Yosa, any final last words before I wrap this up?
For my part, I completely agree with Megan and Al. I think first step would be to create an international network, because what we see is a lot of people have launched a very interesting project with very good outcomes, and we're not sharing that internationally. Like, we know our local initiatives. First thing I think would be to share that internationally, to have a network that can actually learn from the experiences of other countries, even if we don't have the same sanitary system. There are common points, and we can definitely build on the outcomes, and also sometimes there are problems in the projects and they're overcome. And I think if you can learn from experiences from US, from Canada, from Spain, from France, and exchange with other countries, it would be very, very helpful for the future to build something that fits the patient needs and is good for our systems. I think your micro is off.
Yeah, sorry, Yosa, any final words? Otherwise, I'll let people disappear.
Okay.
Thank you. Thank you very much. Thank you. I just want to say thank you to our panel. Apologies for running slightly over. Great contributions. I think that sense of international learning, keeping open each other is really part of what this summit is about, and hopefully will continue to be about. You can watch this session on demand, and there's a short networking break, even shorter than it would have been because I've let it run over. And we encourage you to visit our resources area, which again you can click on before our discussion session starts at 1:30. But finally, thank you again to our panel, fantastic contributions, and to you, the audience, for asking such great questions. Thank you, and take care and enjoy the rest of the day. And enjoy, particularly for our colleagues from the US and Canada who can go back to bed for a couple of hours, I hope. Thank you.
Thank you.
Thank you. Bye.
Bye-bye.